So, how to detect intestinal obstruction on abdominal X-ray, and how to distinguish between small and large bowel obstruction on the abdominal X-ray, and after that, what to look for as a cause of this obstruction. So, the small bowel starts with the duodenum, so we need to talk about duodenal obstruction on abdominal X-ray. So in this case, you will see the double bubble sign of duodenal obstruction. There's a dilated stomach and duodenum. So when you see the double bubble sign, you need to look distally and proximally. You need to look distally for evidence of duodenal stenosis and not atresia. If you see gasless abdomen, no gas in the bowel distally, this is duodenal atresia. If you see air or gas within the abdomen distally, this is duodenal stenosis. This is the first thing. You need to look distally for evidence of gasless abdomen. You need to look proximally for evidence of perforated viscous, if there any air within the peritoneum, free air within the peritoneum, especially around the liver, okay, below the diaphragm. And after that, you need also to look proximally for evidence of aspiration pneumonia because of the obstruction here. Aspiration pneumonia, okay? The last thing you need to look for after spotting the double bubble sign is the bony abnormality because of the common association of the duodenal atresia. Duodenal atresia is commonly associated with bacterial anomaly, okay? So that's it for duodenal atresia. Okay, let's start with how to differentiate between the small bowel obstruction and the large bowel obstruction on the abdominal X-ray. So the small bowel loop from this image, this is a normal abdominal X-ray. The small bowel loop should be located centrally, as you can see here, centrally, okay? The large bowel loop tend to be located peripherally, okay? Also, the small bowel loops tend to cross the abdomen tend to not spare the lower lumbar vertebrae while traversing the spine. However, the large bowel loops tend to cross at higher levels, okay? So, also, the small bowel loops contains folds that traverse the whole lumen called valvuli conniventis. Okay, this is the valvuli conniventis. And the gap between these folds is usually short, okay? However, the large bowel loops contains the hostra, which are folds that do not traverse the whole lumen. Okay, if you go like this is the hostra, tend to not traverse the whole lumen of the large bowel, okay? So let's start with This case. This is an example of a small bowel dilatation, an abdominal X-ray. As you can see here, this is the valvulae conniventis. Okay, valvulae conniventis, which traverse the whole lumen of the small bowel. Also, the small bowel loops tend to be centrally located, as you can see here. And while traversing the spine, they tend to not spare the lower 2 or 3 lumbar vertebrae. Okay, as you can see here. Another example of small bowel dilatation. Look here at this loop. This loop contains valvulae conniventis, which traverse the whole lumen, and the bowel loops here tend to be centrally located, okay? And while traversing the spine, they tend to not spare the lower 2 or 3 lumbar vertebrae. Another example of a small bowel dilatation. As you can see here, valvulae conniventis, which traverse the whole lumen, valvulae conniventis, okay? The bowel loops tend to be centrally located, and while traversing the spine, they tend to not spare the lower 2 lumbar vertebrae, as you can see here. Another example of a small bowel dilatation. Valvulae conniventis tend to traverse the whole lumen. The bowel loops tend to be centrally located, and while traversing the spine, they tend to not spare the lower 2 or 3 lumbar vertebrae. They don't spare it, however, still can traverse the upper levels, okay? Another example. Here's a small bowel loop dilatation. Okay, the valvulae conniventis centrally located, tend to be centrally located. While traversing the spine, they tend to not spare the lower 2 or 3 lumbar vertebrae. Another example, centrally located. They tend to not spare the lower 2 or 3. Can you see this? Yeah, this is the iliac bone. Okay, so here they tend to not spare the lower 2 or 3 lumbar vertebrae and centrally located. Another example. Sometimes the gap between the valvulae conniventis is wider when the bowel loop is markedly dilated, and sometimes there is loss of the valvulae conniventis when the bowel loop is hugely dilated, okay? I think I have here a case with loss of valvulae conniventis due to a hugely dilated bowel loop, small bowel loop, okay? So here tend to be centrally located. Contains valvulae conniventis, tend to not spare the lower 2 or 3 lumbar vertebrae while traversing the midline or while traversing the spine. Let's start with the large bowel dilatation. Can you see this? This is the hostra. This is the hostra, which tend to not traverse the whole lumen of the large bowel loop. Okay, and the large bowel here tend to be peripherally located, okay? And while traversing the spine, they tend to spare the lower two lumbar vertebrae, as you can see here. Here's another example of large bowel dilatation. This is the hostra. This is the hostra, 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 hostra. Okay, which not traverse the whole lumen, and while traversing the spine, they tend to traverse at a higher level of the lumbar vertebrae. Okay, and if you see this loop is the small bowel dilatation. This is a small bowel loop. Okay. In this case, this is a mix of small and large bowel loop. So if you follow the peripherally located loop, it will traverse the spine at a higher level. Okay, and if you follow a centrally located loop, it will traverse the spine at lower levels. Here, this is a large bowel loop which is dilated, markedly dilated here. Okay, and as you can see, it's peripherally located across the spine at higher levels. This bowel loop is a small bowel loop. Okay, so can you see the hostra here? Hostra, can you see the hostra? It's not traversing the whole lumen. Okay. Here, hostra. Here's another example of large bowel dilatation. Okay. Can you see any valvular events here? No. Peripherally located and tend to traverse at higher levels. Another example, small bowel loops dilatation tend to traverse at lower level with a cecal dilatation. Sigmoid dilatation with, can you see these bowel loops which traverse at lower levels? Okay, so this is a small and large bowel dilatation. Here, peripherally located bowel loops, large bowel dilatation. Can you see this bowel loop tend to spare the lower two lumbar? Okay, so this is large bowel dilatation and cecal dilatation. Okay, large bowel dilatation, peripherally located, tend to cross at higher levels. And here, small bowel loops. Okay. So this case shows the main difference between the large bowel dilatation and the small bowel dilatation. Here's the large bowel, peripherally located, crossed at higher levels. Small bowel loops, centrally located, and cross at lower levels. Okay. Here is the large bowel loop, which is peripherally located, and this is a small bowel loop, which is crossing at lower levels, but it's hugely dilated bowel loop due to a problem in the large bowel. I will mention this case later on. Okay, there's air in the bowel wall here. That means that this bowel loop is ischemic, so it's not functioning right now. So this bowel loop is trying to push its content. It's inside the large bowel, which is non-functioning, so it's hugely dilated here from the accumulation of fluid. Okay, so here's the main difference between the large and the small bowel dilatation. Large bowel dilatation, can you see the valvuloconjunctives, and the small bowel loops, which is centrally located and tend to traverse at lower levels. Here's about this bowel loop is tend to traverse at higher level. Okay, but there's a kind of obstruction here. I will mention this case later on. So you need to look for, after spotting that there is a small or large bowel dilatation, you need to look for the cause on the abdominal x-ray. Okay, so you need first to look for the hernial orifices. Okay, if you draw a line starting from the anterior superior iliac spine down to the pubic tubercles, okay, so this is the inguinal ligament. Okay, so if any bowel loop from here is seen traversing this line, so this bowel loop is herniating through the inguinal ligament. So can you see this bowel loop which traversing this line and is seen here? Yes, this is a herniated bowel. If you draw a line here and the line here, this is the inguinal ligament. If any bowel loop is seen traversing, this bowel loop is seen traversing, okay, traversing the pubic tubercles, okay, this is a right-sided hernia containing bowel seen below the pubic tubercles, okay, herniated bowel. Can you see here? This is the bowel loop that decided to traverse the pubic tubercles and continue here. This is a herniated bowel. Okay. Okay. This is an example of bilateral inguinal hernia or groin hernia. This is an example of right-sided inguinal hernia or groin hernia because this bowel loop decided to cross the line from the anterior superior iliac spine to the pubic tubercle. So this is a right groin hernia, and these bowel loops decided also to cross the level of the pubic tubercle. Okay, bilateral inguinal or groin hernia. Okay, after that, the next important thing you need to look for is evidence of any calcified density here or here or here or here. This is gallstone areas. So, sorry, you need to, after this is groin hernia causing bowel obstruction, so you need to urgently refer the patient for a surgery unit because this patient will likely need surgical closure of the abdominal wall defect through which the hernia has protruded. Okay, so this patient needs These patients need surgical referral, urgent surgical referral for surgical closure of the abdominal wall defect. Okay. Also, you need to check for any calcified density after you spotted the dilated bowel loops. Okay. Check for evidence of calcified density. Here, there's a calcified density here. There's a calcified density here. Calcified density here. Calcified density here. So the diagnosis will be gallstone ileus. Okay. So the diagnosis, gallstone ileus. How to manage? I would recommend a CT scan. Okay. I would recommend a CT scan and an urgent surgical referral, as this patient will need surgical removal of the impacted stone by making an incision in the bowel wall. This is called enterolysotomy. Enterolysotomy and surgical removal of the impacted stone. Okay, so what about how to manage the duodenal obstruction? I'm sorry, I didn't mention how to manage the duodenal obstruction. I will urgently convey the findings to the referring physician and recommend GIT surgery referral, as this patient will need surgical repair called duodenostomy, which means surgical excision of the duodenal atretic part and anastomosis between the healthy duodenal parts. Okay, I will mention. We'll try to type this one here. Means surgical excision of the atretic duodenal segment and anastomosis between the healthy duodenal. This condition can be associated with vectoral anomaly, so this patient will need a further workup to assess for any additional abnormalities, okay, any vertebral abnormalities, any anorectal abnormalities, any tracheoesophageal abnormalities, any renal or limb abnormalities, okay, and any cardiac abnormalities. So, yeah, this patient will require a workup to assess for any additional abnormalities of the duodenal atresia. So that's all, and thank